my name is Carley, and I did a systematic review on restless leg syndrome in pregnancy. Let me tell you a little bit about restless leg syndrome to start. It's an urge to move your legs, often accompanied by paresthesia, which is a tingling or pins and needles kind of feeling. It's alleviated only by movement, and it's intensified at evening hours and when you're relaxing and when you're laying down. This is a video that will give you a little picture of what restless leg syndrome looks like. As you can see, that definitely would be a hindrance to sleep. It would be very difficult to sleep. Like I said, there's criteria involved in restless leg syndrome. It's the urge to move your legs. It's only alleviated by movement, and it's worse at night and when you're lying down. So there's two types. The first type is idiopathic, which means there's no cause to it, and the second type is secondary, which I'm going to be talking to you about today. It's secondary because it's in relation to pregnancy and it's caused by things that are occurring during pregnancy. It's a transient usually in pregnancy, which leads to an underdiagnosis because it usually goes away a couple days after delivery. So why does it matter if it's transient? It matters because there's women that are having complicated deliveries because of it. They are experiencing operative deliveries, which is more complicated for the mother and the baby. Also, they already have an array of symptoms that are happening to them. They're pregnant, they're gaining weight, they have gastric distress, they're having difficulty breathing, so they lie down and they're trying to sleep and they just can't, and this is just adding to it and adding to the fatigue. So there isn't a known cause to this that you can pin down specifically, but there are a lot of risk factors. So one of the main risk factors is that women are just naturally twice as more likely to have it than men. Also, the more children that you have, the more likely you are to have it, and also the more increased in age you are, the more likely you are to have it. There's pre-existing conditions that can predict, maybe not, are not risk factors, but they can predict restless leg syndrome, growing pains. One study showed that 42.1% of women with growing pains were seen to have restless leg syndrome in pregnancy. If you already have a central nervous system dysfunction, such as something that's affecting the dopamine, which affects movement and sleep as well, this could be something like sleep apnea, you're a lot more likely to have restless leg syndrome in pregnancy. Idiopathic restless leg syndrome is obviously not going to go away once you're pregnant, and it's often exacerbated due to the lack of treatment options because you're pregnant, so you can't take your normal medication. As well as if you've had previous secondary restless leg syndrome, you're a lot more likely to experience it again. One study showed that 58% of women that had previous secondary restless leg syndrome experienced it again. As I said, there's a lot of other factors that are occurring during pregnancy, such as this increased stress on the body, weight gain, shortness of breath, things like that, which just open a woman up for other sleep disorders because they're already fatigued. Physiologically in pregnancy, your hemoglobin decreases, and so in restless leg syndrome, this is a known risk factor. So this does not help even though it's a physiological condition. Also, it's the same with prolactin. Because it's increased, it can definitely predict that you're going to have restless leg syndrome. Iron deficiency is a widely known risk factor for restless leg syndrome, idiopathic and secondary, as well as folate is becoming more and more significant as time goes on. An undermodulation of the thyroid hormone, because the thyroid hormone affects dopamine production, which, as I said before, affects your sleep and your movement. Restless leg syndrome is definitely seen to be prevalent. It is between a range of 11 to 34% of pregnancies are affected with restless leg syndrome, which is a fairly significant amount. The origin of symptoms is usually seen in the third trimester. That's why it's often missed and not diagnosed or treated. There are treatment options, even though they're not necessarily being used. A lot of times women just need a reassurance that this is not some kind of seizure disorder, such as preeclampsia during pregnancy. They need to be taught that there are relaxation techniques that they can use. They can take a hot bath, they can get a massage, they can stretch their legs, but they're not being taught these things. They can eliminate coffee and chocolate after noon. Eliminate large meals, other things that could just aid in sleep hygiene, as well as a supplementation of the things that they're already lacking. There have been some medication tests done, but as you can see, the first study was tested on only 2 women. They did experience a relief of symptoms until they stopped taking the medication, but it's not really significant since it was only 2 women. Dopamine receptor agonists, opioids, anticonvulsants, and benzodiazepines have been used, but the risk versus benefit doesn't necessarily weigh out because of the effects to the fetus. So my specific review was a 21 study review. I used the Robert Morris online library, and I compared and contrasted and synthesized my information into a tabular form, which I have here for you. I'm not going to read through all of this in the extent of time, but I will discuss a few of my significant findings. So there was obviously a prevalence, as you can see. These were significant studies that were done. There's a study of 524, 16,528. These are significant studies that are happening, and there's 20% of women had RLS in pregnancy in a study of 16,000. That's significant, and it needs to be treated. As well as you can see, it's often seen in the third trimester. There are these risk factors that we're seeing over and over again that aren't being treated that could be addressed. Growing pains, as I mentioned before, the increased age, previous secondary RLS, depleted iron was a huge one. We just saw it over and over again, as well as this lower folate, hemoglobin, increased estrogen. These are things that can't really do much about, but we can address them. Family history was also seen to be huge, and you can start taking supplements before if you know this is going to be a problem. Another thing that was seen in the research is that this is affecting people. This isn't just something that you can get over and it's not a big deal. It is affecting women. These operative deliveries, the long vaginal deliveries, it's truly a problem, and it's harmful to the mother and the fetus. 32.1% of women still suffered from RLS 3 years later. This is significant. In a study of 500 women, that is significant and needs to be addressed. So I've developed recommendations for future practice so this can be addressed. First, you need to acknowledge these women's symptoms. You need to tell them there's not direct harm to the fetus, and it is not a seizure disorder. They need to be educated on relaxation techniques. Whatever works for you, but it needs to be a relaxation technique, as well as potentially a distraction technique, as you can see with like the handheld gaming devices. It's something that distracts their mind. It's not going to cure these symptoms, but it will alleviate them and help them to relax. I recommend eliminating caffeine and chocolate entirely, not just before noon, in order to efficiently work with the symptoms. Strenuous activities and exercises should be limited to the morning so that later on your body has time to relax, and it can be in this relaxation pattern and hopefully not still be worked up throughout the day. Iron, folate, and folic acid supplementation should be continued not just during pregnancy but during childbearing years in order to have a normal, and so that when it does drop off, it's just a slight fix during pregnancy, nothing dramatic. I wouldn't recommend pharmacological treatment because the benefit does not outweigh the risk. There's rarely a time, but there are exceptions, and there are a few treatments, as I mentioned before. Education about this transient nature and the possible relief is huge. We just need to educate these women about what is happening to them. We need to educate them not just when they come in with these symptoms, but during their whole pregnancy, during when they come for their first well visit. so that they're prepared and know what treatment options are available, and they're not taken aback when they're in their third trimester and they're experiencing these seizure almost like disorder. These are all my references. And any questions, but at the end.